Mit Ham Kehillah Agdeutsche will mir jetzt melden, als lieb die größte Nachfrage haben bei Nacht, hat mir schon Messade gewähnt, also mit dem Teikev noch Jantev, wird vorkommen, mit dem Duen Saal noch als Siefe, von der Nuschen Zitkunies, auszuschmissen, Bebrutius, die wichtigen Jungen, wo sie davon zu wissen. And now, to the high point of tonight's event, we have a panel of distinguished doctors and professors who've been serving our community in a variety of specialties. We'll have this program moderated by Dov Landau, who he himself has been servicing the community in his own practice for a number of years with extreme devotion. Dov.
Shis kol akol, ich kikarim, Raboi sei, das ist von mir a größe Schiss, zu stehen mit euch allem ein paar Nacht. Das sei ein spezieller Moment. Auf Englisch wird man gesagt, es ist a monumental occasion von mir. Über alle Jahren habe ich gewundert, wenn geht kommen dem Tag, was ich erkennen Stein, oder nicht mich, aber Menschen will nehmen ernst wegen preventative medicine. Ich rief den Moment, ein paar Nacht, bei mir im Kopf, ich rief das ein Herschel-Weber-Moment. Wir stammen ihr alle, kicken mich an, was mischte Hatzule mit Prevention, mit Primary Care, was hat das zu tun? Herschel hat gemacht Hatzule. Lass mich auch maßbar sein. Auf Englisch rief man Hatzule EMS. EMS in primary care kommen zusammen. They may look like polar opposites, we say in English, but they are very much intertwined. Sie kommen zusammen. Koidem kol, bei Chassidei Umas HaOlam, am rief tun EMS, holt man nicht auf das Telefon. Pinkt das so wie man rief der Primary Care Doctor in ganz Amerika, man holt nicht auf das Telefon. Das ist dasselbe Problem. Man holt ja auf das Telefon, kippt man schon noch nachher am meisten. So, sie kommt zusammen. Primary Care, als sie stark und sie geht, ist eine Sache weniger Hatzule-Calls. Als sie schwach, leider darf man suchen, eine Sache mehr Tillen, man hat eine Sache mehr Ambulanzen von Hatzule, was fuhren nach hinten zurück. Es kommt sehr stark zusammen, zu sein du heint mit Hatzule. Wie kommt an Herschel Weber? Warum rede ich wegen Herschel Weber? Warum habe ich getragen wegen Herschel Weber? Herschel Weber hat nicht gekauft ein fancy Airplane, in einer rumgefuhrene Welt, Menschen in Cleveland Clinic, in Mayo Clinic. Ich meine, er ist ein Pushete Jid, hat gekauft ein Telefon mit einem Oxygen-Tank und geworden, wie man rief auf Englisch, a Trailblazer. Ich bete bei euch, mit der Trailblazer, jeder eine, du weißt, in Gebäuden gewachsen, der beste Hatzule in EMS auf der ganzen Welt. Du in Williamsburg, du der beste EMTs und der beste Paramedics und der schnellste Hatzule, du bist der Envy of der ganze EMS von der ganzen Welt. Ich bete bei euch alle, ich hoffe von Heint un, als jeder eine, was steht in der Zimmer, so werden bei sich allein ein Herschel Weber, wie soll, nehmen zum Ernst zu lernen, als Chotscha Filu, als der Healthcare System zusammengefallen, sei in der EMS in der ganzen Welt, und sei in der Primary Care, es ist schwer zu uns zu kommen. Der Sibes wird man nicht reden, du wegen ein paar Nachts, das andere Sibes ist du kein Geld, ein anderes Sibes, als Ayid will es machen, Achusset will es machen, geht es sein, es geht auf dem besten Häufen sein. Als jeder eine, was setzt du in der Zimmer, wird wollen, als in Williamsburg soll sein der Envy von der ganzen Welt, nicht nur von Azula, sondern euch von der beste Primary Care, ist von Heint und bei Nacht, wird in Williamsburg sein der beste Preventative Medicine auf der ganzen Welt. Jeder eine wird sich umkicken auf Williamsburg und sagen, das ist nicht nur der Platz, wo du der beste Azula, das ist euch der Platz, wo du der beste Primary Care. Und mit dem will ich auch danken, Shulam Yosef, weil ich weiß, wie stark und wie arbeitet, Stilleheit, schläft nicht bei Nacht, wie arbeitet zu bringen, als der Primary Care soll sein, mit Messide, mit seinem eigenen Leben übergeben für jeden einen, so Tage umkommen soll sein, also auf dem besten Neufen. Nicht du so viel Zeit, aber man geht scratching the surface. Ich will schon gehen zu den Doktoren, in introducen die Doktoren, weil ich will nicht später in der Zeit schmissen, ich will reden, praktisch gerät. So I'm going to switch over to English. I'm humbled tonight to stand before such honored doctors who I know have dedicated their lives to helping the community and that understand the unique risks and characteristics of this community. I remember, I'll start first with Dr. Hochster, a renowned oncologist. I remember when I just started in Williamsburg, probably about 20 years ago, a young man came in very late with cancer, and he did everything he can to save this man's life. I'm sure he doesn't remember me, and he doesn't remember the story, but I remember what he did. Welcome, Dr. Hochster. I think Dr. Shakui doesn't need an introduction. I think his name is a household staple in the community, and so is Dr. Berlin. Dr. Bander, if you didn't know him as the chief of cardiology in Mount Sinai, he was one of the few that stood up for the community and did everything he could during COVID. During COVID, I woke up in Valley Hospital in Ridgewood, New Jersey, and somebody was telling me they didn't take you out to Dr. Bander in Mount Sinai yet. So that's what I can tell you about Dr. Bander. His name is synonymous with Mesiras Nefesh for the community. Of course, Dr. Halberstam, I've heard how amazing he treats all our endocrinological cases, and I'm sure we have a lot to talk about tonight and a lot to learn about the pathophysiology that's grossly misunderstood and needs a lot of education. Dr. Halberstam, the heat's going to be on tonight. GI, Dr. Ramani, and your associate, Dr. Horowitz, I can't underemphasize how much pathology, you've heard all about that from the speakers before me, we see in primary care, but I think, and that's what we'll talk about tonight, the primary misunderstanding is there's such a window of opportunity to intervene and treat if you just come early. So without further ado, I think I'll just go in the order of questions by specialty. Dr. Shakui, or your associate, Dr. Berlin, would one of you please come up or take the mic if you want to stay in your seat and explain us, what does it mean a primary care doctor? I don't have a primary care doctor. When I don't feel good, I stop by the Doc in the Box at any corner on my way home from work, and I check myself out. What does a good primary care doctor mean? Does he have to have a good education? Does he have to have years of experience? Does he have to pick up his phone when I don't feel good after hours? Does he have to have good associates? Can you explain our crowd, what does primary care mean? And I'll just add in a few other questions and you'll pick out what you have time for. Can you give us the milestones as we age of what you would consider the primary important tests we should do at what ages, what annually? When should we get an EKG? When should we get a urinalysis? When should we get our A1C and lipids checked? When do we get a bone densitometry or a PSA level? Can you speak to tell us educate us on what primary care, the backbone, the branches, not the branches, the roots of the tree of medicine that is greatly deficient in the country and in our community and misunderstood. Can you explain that to us?
Okay, large crowd. Thank you all for coming, and we appreciate that you want to listen to us. So I want to start with something that it's not going to go in the order of the questions. I want to tell you something that unfortunately I think is being neglected. So we discussed today about all the things that you need to do for primary care, all the prevention type of things that you need to do. You know, do the colonoscopy, do the blood test, check your blood pressure, do all of those things. I think these are very important, and this has to be done. It's very, very important. But I want to talk about certain basic guidelines that we all need to do in order to be a healthy individuals. So let's start with just a few basic things. Number one, I think body is made of 70% water. Do you guys drink enough water? Water is a very essential thing for your health. You know, we talk about colonoscopy, this and that, but what about the basic things? Drinking water. We all need to make sure that we drink water every day. It's important because you don't feel thirst unless you're 7% dehydrated. So you really need to make sure you drink water. How many of you take deep breath every day? You know what a deep breath does to a person? Deep breath puts you in a space of relaxation. And when your body is relaxed, the body can heal. The body can do the job to make itself better. What do we need to do as far as the food? We need to avoid sugar. Sugar is the number one killer that is in this community more than any place else. We really need to take care of that. Sleep. How many of us will get enough of sleep? We need to take care of that stuff. You know, we need to get enough of sleep to be able to function properly. We don't need to go on sleep deprivation and just drink coffee and coffee and coffee in order to function. That's not important. So I think a primary care, the role of a primary care is to teach you how to take care of yourself. The more you take care of yourself, the more your body will act accordingly. You need first to take care of the body. The body was designed by HaKadosh Baruch Hu to do the job correctly. All you need to do is to give it the right tool. Help yourself by giving yourself the right tool. Drink water, avoid sugar, exercise, do all those things. When you do that, the body will help itself and will do that. You know, I brought something to just give you an idea. This is simple tools that all the Hatzalah guys have. This is a pulse oximeter, okay? When you check your pulse, I want you to just go, whenever you go to the office, just check your baseline pulse, okay? When a person checks his baseline pulse, you want your baseline pulse to be very low. Do you know how to bring the baseline pulse lower? Very simple, deep breathing and exercise. My baseline pulse is about 53, okay? Most of you would counter that baseline pulse is too low, but that's the way the body's supposed to be. You need to do the exercises, you need to take care of that. So a primary care is a person that will teach you all of those things. When you go to a primary care, it's not about just, you know, looking at you, talking to you, doing this stuff for you, but rather trying to give you the basic guidelines of what it means to take care of your body and to be healthy. So I wish you all that in this gathering, at least you get the things to take care of your body, to take care of that. And unfortunately, there was a part that I think was missing, the mental health of the community. Unfortunately, the mental health needs to be addressed. And we know that there's a lot of stress that is going around and a lot of diagnosis going around, and we really need to take care of that part. We need to take care of our mental health. We need to address those stuff because mental health causes physical health causes mental health. We need to address both of those things in order to make ourselves healthy adults.
I would now like to introduce to you Dr. Ramani, who's a renowned gastroenterologist, and his associate, Dr. Horowitz. My first question for you, Dr. Ramani, is I'm of age, which you'll discuss the ages, to get my colonoscopy, but I don't want to go. I don't want anything invasive. I have siyata d'shmaya, whatever Hashem says is going to be, and I'm not taking anesthesia, and I don't want anything invasive put inside my body. Could I just do a Cologuard or a fit test once a year, or maybe a capsular endoscopy? Would that work, Dr. Ramani?
It's a very good question, and it's a question that I'm asked very often. I would bet that if I go around this room and ask every single person in this room if they would be satisfied with the second best shidduch for their son, or the third best shidduch for their daughter, or their grandson or grandchildren, I'm pretty sure I'm not going to find one person that would answer affirmatively. That would say, yeah, sure, I'll take the third, fourth, fifth best boy that's available. Everyone wants the best, right? We're Jews. We want the best. We want the best restaurants. We want the best shuls. We want the best Rav. We want the best shidduchim. And yet when it comes to our health, it's very common, at least in my field, where people are trying, unfortunately sometimes, not just our community, this happens all over the place, but we are willing to give up on these amazing tools that Hashem provided for us. We're willing to forego those and settle for second best and third best and so on. I will admit that this used to be a much bigger issue. Thankfully, because of events like this and because of events that have been going on with Maktim, with Chaim Fleischer, who I think is here tonight. I heard his name, my Yiddish is not great, Sephardic, but I heard his name. The name is the same in both, in all languages. So we've made a lot of progress, but you want to do the lechatchila thing for your health. And, people, Shomer Patayim Hashem, I hear that a lot, Shomer Patayim Hashem. And I think I heard the Dayan say this, that Shomer Patayim Hashem means that you have to use the tools that Hashem provided for us. I'm not here to give musar, but as a doctor, when you have something like a colonoscopy that's 95% effective in preventing colon cancer, which was at one point in this country the number one cause of death, why would we ever want to settle for something that's second best or third best? It doesn't make any sense. So I think that's the first thing that we have to really take into account. As far as Cologuard, as far as all these other tools, again, it's a very common question. Cologuard is a stool test. There's other stool tests that are available. Cologuard is not intended to prevent colon cancer. It's a very important distinction. So a colonoscopy, the idea of a colonoscopy is to find polyps, remove them before they have a chance to turn into colon cancer. Cologuard is able to detect colon cancer once it's actually cancer. Again, if I would go around and ask every single person in this room, do you want to be able to find something before it turns into cancer? Or do you want a test that will hopefully find it once it's cancer? I think the answer would be very, very obvious. You would go for the test that's able to prevent colon cancer. Even when it comes to its intended objective of finding colon cancer, Cologuard has about a 10 to 15% false positive and false negative rate, which means that you can get false answers. When you look at polyps, which is what we're able to find with colonoscopy, the New England Journal of Medicine did a study in 2018, and more than 50% of polyps were missed by Cologuard. So again, it's a good b'diavad to have. It's better than nothing. If somebody is not a candidate for colonoscopy, certainly it's better than nothing. And a lot of times I will use it as an initial test to get people to do a colonoscopy if it comes back positive. But obviously it's not a replacement. It's not a substitute.
Thank you. A couple of more questions. Being that the rate of colon cancer is higher in our community, do you recommend an adjusted younger age to get started? And also, I have some patients in my practice that developed colon cancer without knowing their family history, familial polyposis. Would you recommend any new genetic screenings be more widely implemented in our community, being that we have a higher risk?
Excellent question. I will tell you that over the last 10 years, the numbers have shifted a lot. It used to be that for an average risk person, which means that somebody that doesn't have any family history, the latest that somebody should get a colonoscopy was 50. Around 4 or 5 years ago, they changed it to 45. I will tell you from sitting on panels that discuss this on a national level, that over the course of the next 2 to 3 years, it's going to probably become 40. And the reason for that is that by the time people were coming for the colonoscopies, even if they were doing it on time, they were doing it when they were 50, unfortunately we're finding cancers already. Again, the idea here is makdim before the maka. We're trying to get to a point where we don't see the maka. So as time has gone on, and it's unclear why this is happening, if it has to do with the foods that we're eating or the environment or stress, but certainly people are being found, unfortunately, to have polyps at a younger age. So the general consensus now is for an average risk person, which means that if there's no family history of colon cancer, the latest somebody should get a colonoscopy is 45. If there's any family history, and unfortunately what you said is true, that there's a higher rate of GI issues in general and colon cancer specifically, then the latest age that somebody should get screened is 40 or 10 years younger than however old that relative with the colon cancer was. So if somebody has a relative that was diagnosed at 45, the latest that the immediate family should get screened with their colonoscopy is 35. Another very important thing to think about, and again, this is something that Dr. Halberstam, again, I think I picked up this notion, is that it's not just colon cancer in family members, it's also polyps. So if somebody has a high-risk polyp, which means a precancerous polyps, which again, most polyps are, that counts as the same risk factor for the family members as if it's colon cancer. So if somebody's brother, father, sister, child, God forbid, gets a colonoscopy and they're found to have a colon polyp, the first degree relatives have to be screened 10 years younger than that person. It's very important. And it's also very important, I always tell people when I find a polyp, your mitzvah for today is to go home, call all of your first degree relatives, and tell them that they have to get their colonoscopy by this age. Unfortunately, I do find that there's a stigma in our community with people not wanting to talk about their medical problems. If every single person here, there's a lot of people here at Baruch Hashem, if you would look to your right and to your left, I guarantee you, and I could tell you because I've seen a lot of people in this community and all over, that it's almost impossible that you don't have a family member that has some sort of a GI issue or polyps or so on. So there's nothing to be embarrassed about. This is how you can mamish save lives. You don't have to be a doctor to save lives. You could be a patient, you do a colonoscopy, they find a polyp, tell your relatives, go get your colonoscopy at a right age, and you can mamish be matzel nefesh by doing that.
So before I go on to the next question, I think that was very important information to unpack. I want to recap it with you. The current recommendations for the general population is 45. Your recommendation is we should already turn it in our community to 40, and 10 years before any polyp that any first degree family relative, brother, sister, mother, father, grandparents even, have had a polyp, everybody else in the family should be doing it 10 years before. Moving on to the next question, do you think it is in part our diet? Is there any significant adjustments that you think we can do to help mitigate our increased colon cancer risk? Or is it all genetics? Or what else do you see and hear in conferences, literature, that you think may be affecting our community's high degree of colon cancer?
So I think there's a lot of genetics that's involved. And again, I think one of the real nisim that Hashem has brought down for us is the fact that we have something now to counteract the genetics. I think that environment and also our habits do play a very large role in colon cancer. Two of the risk factors that we know when it comes to colon cancer is increased red meat intake. So specifically with processed red meat, so things like salami, pastrami, all those kind of things. If there's an increased intake of those types of foods, then there's definitely a higher propensity for colon polyps. So one of the things that you could actually modify is your diet. If you have a very high intake of those type of foods, that type of meat, my general rule is that you really should not, nobody should be having red meat more than once a week. And thank God we have Shabbos. So that means that during the week, unless it's really a special occasion, you should really think about having, chicken or fish or vegetables before, you go ahead and have red meat. That's something you can modify. The genetics we can't modify. This can. And I think the second thing, which is a huge factor, is exercise. I'm sure there's going to be other doctors here that are going to talk about exercise. But at least from a GI perspective, we know that increased body girth and increased body fat increases the chances of colon cancer and polyps. So the more exercise, and the general rule with exercise, it doesn't mean walking to shul and walking back from shul to home. There has to be at least 3 hours a week, ideally, if not 3 half-hour sessions every week. That's the least that all of us should be exercising, and it should be a type of exercise that's actually getting you sweating and getting your heart moving. And those factors are, I think, extremely important in being able to mitigate our risk for colon cancer.
So I think the most important take-home point that most people need to hear, I would say, is reassurance. Let me tell you, as having been a patient that did a colonoscopy in the last couple of months, it's not nearly as scary as it sounds. You're over and done with in no time. You feel nothing. It's very safe. Any potential risks are very minuscule. And before you know it, you have your report in your hands and you're on your way.
So my first question is, how come you didn't do your colonoscopy with me?
Because I live upstate.
I'm kidding. Not looking for a new business, please.
It was your friend, Eric Tater.
Oh, good guy. Okay.
So it was actually the only time I took a vacation. To quote the GI doctor, here's your pina colada. And the next thing I knew, I was out the door with my report. So, Mama, it sounds very scary and invasive, but it really doesn't feel that way when you go through it. So I think the fear factor is the biggest factor probably in the room. It sounds very traumatic. I think that's the part that needs to be broken more than anything else.
Yeah, and I'll conclude with that because I think that's the most important thing. People are scared of colonoscopies. I see women that have had 14 children and they're terrified of doing a colonoscopy. Just so you understand, there's 2 steps to it. The day before, there's the preparation, which everybody talks about. It's really gotten so much easier over the years. Now there's pill options, there's small bottles that you could take, and the idea obviously is in order for us to be able to find these polyps and prevent colon cancer, you have to be able to see the colon. So the cleansing process has gotten much easier. The procedure itself takes about 15 to 20 minutes. They give you a little bit of sedation through the IV. It's not general anesthesia, so basically you're sleeping the same way that you would be sleeping at home. You're breathing on your own. We do monitor everything, but again, there's no paralysis, you're not paralyzed, you're sleeping exactly the same way you do at home, and you wake up on average within 90 seconds of the time that the colonoscopy is done. If we find anything, more than 95% of the time, we take care of it on the spot. So this is not like, going for a mammogram, which is also obviously very important, where if they find something, you have to go for a biopsy or a sonogram. Whatever we find in a colonoscopy, we take care of right away. And in general, most people do not need to come back more than once every 5 years. But that first colonoscopy to establish your baseline is extremely important. The most common question that people ask me after the colonoscopy is, when is my procedure starting? Okay? That's how easy it is. Obviously, it is a procedure. There's always small risk and things like that we'll discuss with you. But again, the colonoscopy itself or the preparation should never be a reason not to take advantage of this tool that we have, which could be life-saving.
Thank you, Dr. Romani.
Thank you.
Moving on right along. Dr. Jeffrey Bander, world-renowned chief of cardiology at Mount Sinai, head of the COVID unit at Mount Sinai. I don't know how many more titles I could give him. Dedicated doctor par excellence, like everybody else here. Can you please give us some insight into a very common problem in our community? Hypertension. We have a lot of patients walking around with a big silent killer. If we stood here with a blood pressure cuff by the door, which I believe every shield has a Hatzula member should do, take everybody's blood pressure, I wouldn't be surprised. What do you think the number would be of how many people have hypertension, borderline hypertension, labile hypertension in this room? 40%, 50%? I don't know the number, but it's up there. So the first question for the night is, why are the US guidelines coming down? Why are we tightening up the recommendations as opposed to Europe? Why are the recommendations no longer 140/90? Why did we lower it to 130/80? Can you speak to that?
So, first of all, blood pressure numbers are complex. And so many of you have taken blood pressure and it's 200/100 one day, and the next day it's 120/60. So before we say what your blood pressure is at a given moment, we have to acknowledge that blood pressure, while it's an important number, is something that you have to measure over many times. So many people who've been to my office know you might come in with a blood pressure of 190/90, and I'll tell you, you know what? Go to sleep, have a good night rest, measure at home, come back and see me in 2 weeks. So the number itself is not just a one-time thing, it's something that we check all the time. Now, to answer your question directly, 50% of people in this room have high blood pressure at some point, okay? That's the right answer, looking at the general age of the room. Now, why are the numbers so important, and why do the guidelines keep going down? So one, by looking at studies, and they take patients and they say, if I measure your blood pressure and it's controlled, and I have someone else who's similar and their blood pressure is not controlled, their risk of having a heart attack and a stroke is 4 times higher. So if I would take a blood pressure that's high and reduce it by 10 millimeters, 10 points, either in the bottom or the top or the average, I will reduce your risk of having a heart attack and a stroke by 25 to 50%, just by lowering a number. So that's why we're all focused on simple things like blood pressure numbers or cholesterol numbers. So blood pressure in itself is known to be the biggest risk factor. However, what's important is to know what your number is and to know what it is over time. So it's an easy thing to target, and everyone's individualized. And I don't think it really matters how you get there. So some people come in the office, they're young, they go on medicine. Some people can go on vitamins. Some people go on exercise and diet. It all depends. And I think the take home, we talk about prevention, which is the key here, but I think it's also individualized, meaning what goes for one patient doesn't go for another patient. So that's why a lot of people say, my friend, he's not taking medicine, I don't want to take medicine. Well, your friend didn't tell you that his mother and his father had a heart attack at a young age, and we talked about that before. So we have to be very careful that what fits for one person is not for another. The guidelines, and the thing about Williamsburg and the from communities, everybody's very smart. They ask questions. Nobody just says yes sir, they don't listen to the doctor, they ask. So you have to understand that while we say lower your blood pressure, lower your cholesterol, there's a lot more to it from the individual that we analyze whether or not you need to be on medicines or diet or exercise, or we can ignore it. Not everyone needs to be treated, but everyone needs to be analyzed for it to see what they need to do.
Thank you. So just to recap that, are you encouraging somebody who gets clocked in preliminarily with an abnormal number to go by, say, an Omron machine and randomly check it between doctor visits? And how long should he follow up? He clocks at 140/90, he's seeing his primary care doctor. How often would you say as a cardiologist he should be monitoring it? Now he's 28 years old, a little overweight. Yeah, he knows he needs to exercise, he needs to diet to get it better. Not so easy, we'll talk about that. What would your best protocol be for him that he doesn't get lost to follow up?
Again, it's very individualized. Somebody who's young, is not overweight, has no significant issues, we'll tell them to monitor at home and come follow up in 3 months. If they're overweight, we have to check, are you snoring at night? Do you have a family history? What's your kidney function? There are some rare things that we check. So I think everybody who has a high blood pressure 3 times and above, in an office needs to go at least home and monitor it at home with their own cuff that they can buy, or ODA has these programs where they can give you a blood pressure cuff if you have certain insurances, and they can be monitored at home. I think the guidelines have moved towards measuring at home. If you measure in an office, everyone's nervous. So most people are going to have an elevated blood pressure. With the automatic cuff, even with the manual cuff, just being in the presence of a doctor will make it high. So young people, because it's important, even though it's likely to be normal, we would tell them to measure at home. If there's any question, an EKG or an echo can easily tell us if you've had high blood pressure for a long time. And that's what's really, really important. If you've had high blood pressure for a long time, you can come to the office, do an ultrasound. Your heart's a muscle. Everyone who's come to me has heard me say that. If you're pumping against high blood pressure, young or old, your heart will be thick. So even if you come to the office and your blood pressure is high, but your heart muscle is normal and your kidneys are normal, we know probably your average blood pressure is not as high. So it's worthwhile to check. We don't just throw people on medicine because the number is high a few times, but we check.
Can you talk to us a little bit more about cholesterol management and a realistic exercise management plan?
Cholesterol is just like blood pressure. There are some people in this room who look exactly the same, whose goal cholesterol, bad cholesterol, can be 140 and there's nothing wrong with them, and the person to the left of them could be 70. Why is that? Why is that? Well, it really, really depends. Cholesterol is just something we know is on a level of everyone. People who have high cholesterol tend to have more heart and stroke issues because cholesterol is the building block of disease. However, everyone knows somebody that the cholesterol is 200 and they smoke and they never had a heart attack and a stroke. So is that raya that you should have high cholesterol and smoke? No, there's more deeper factors to everything like that. So you have to check. So we now, other than just checking cholesterol, we have much better ways of telling you, do you need to be on medicine now? Do you need to be on medicine early? Do you need to recheck it? So if you are over 40 and you have a family history, there's something called the calcium score. And for $100, you can get a little x-ray that's going to tell you, do you have the beginning of plaque? If you do, we have to hemodoctic on your cholesterol and get it lower. If you don't, we can wait. So I think realistically, anybody that has a risk at the age of 40 that has high cholesterol should be checked out, and then we can make a risk assessment if you should be treated or not. Not everybody with a high cholesterol needs to be treated, but they do need to be decided on whether or not you need to have further investigation.
Are there any other labs that you like to see your borderline hypertensive patients get, like lipoprotein A? Is there anything else you're concerned to see them come in with from their primary care doctor?
From the primary, that's really just family history is probably the most important thing in a young person. By the time you have chest pain or shortness of breath, you've missed a boat by 10 years. The disease takes 10, 20 years usually to develop, and it's silent, which is why the whole focus on all the diseases. We're all the same doctor here. We're all yelling and telling you, you gotta prevent, you gotta prevent, you gotta prevent. So it's very simple. We don't need fancy tests. We need cholesterol, we need hemoglobin A1C, we need your blood pressure. From there, just talking to you, we can make the decision. So no, I don't need a fancy test. I just need a cholesterol check by age 40 or earlier if you have a family history.
Thank you, Dr. Bander. We have with us a renowned oncologist, Dr. Hofstar, and we thank you for joining us tonight. I'd like to ask you, can you speak to us about the most up-to-date current general cancer screening guidelines? And particularly, is there anything that you would tweak having a good understanding of our community's genetics and unique lifestyle and risks? And when we're at that, we can include, any new genetic testing. Of course, there are specific cases, but in general, and then I guess if you want to address specific cases that come to mind, if you can bring that out. And any particular stories that come to mind where you feel really bad that they haven't had routine screenings like colonoscopies, and then it really ended up as a very difficult case on your hands, and you really wish it could have been prevented, obviously without giving patient details, something that we could take as a take-home message about why prevention is so important.
Well, thank you very much, and I'd like to thank ODA, Rabbi Ausch, RCCS for inviting me to to join you this evening. It's a pleasure to be here and to be able to speak to all of you. I want to first compliment the community and all these organizations on their community advocacy. There are so many communities and so much talk today about being advocates for your community. I mean, this is already highly developed, and you're the first people, the real leaders in this, within this Williamsburg community. So I really want to thank everybody who's dedicated to the health of the tzibur and making everybody easier access to health care. So for screening for cancer, you've already heard a lot about colonoscopy, and I agree with everything that was said. The one thing I want to emphasize again is colonoscopy prevents colon cancer. If they take out the polyp, it's gone. You won't get colon cancer. And this has been shown in gigantic randomized trials that colonoscopy is very effective at keeping you from getting colon cancer. So you really should follow the guidelines that were already discussed by Dr. Rahmani. The second thing, I think, is screening for lung cancer. So I don't need to talk to any of you about mammograms, so let me go to lung cancer. There's more smoking in this community than in a lot of communities. And today we can detect lung cancer early through fast CAT scans that are very easy to have done. They're very quick. And the recommendation is if you're 50 years or older and you have 20 pack years of smoking history or more, you should go for one of these screening lung CAT scans to see if you are at risk for developing lung cancer. And if we find something that's suspicious, it can be tracked or it can be removed at the earliest stage, and it can be cured with a high probability. So I think, first of all, people should, from a lifestyle point of view, stop smoking. We need programs to help people stop smoking. But if you have smoked a pack a day for 20 years or 2 packs a day for even 10 years, then you're at high risk once you get to age 50 and you need to get screened for lung cancer. Mammograms and so forth, I don't have to really discuss that much. It's been already mentioned. But again, cancer is, there are 2 million cases a year of cancer. So 1% of the people in the United States will get cancer. And if you have bad cancer, you may end up seeing me. So let me say to you, I should only see you off simchas and don't come see me in the office. But, you know, we can help ourselves by better diet and by exercise. Everybody this evening, all the Rabbonim were quoting Rambam. Rambam said we should eat a healthy diet, what we would consider a healthy diet today, 1,000 years later, and to exercise. You've already heard the recommendations about exercise. That those things can all help prevent cancer. So, other question?
Yeah, I mean, if you were able to speak to the bachurim, the teenagers that are now just beginning to take up smoking, what would you tell them?
Chew gum instead. Do something else.
What about other cancers like skin cancer, melanoma, prostate cancer? Anything you want to discuss with the crowd today about?
Well, you know, skin cancer has a lot to do with sunlight exposure. I mean, if you do spend a lot of time outside, so if you're not a yeshiva bacher and you're out fishing every day, you might want to put on sunblock. But I don't think that's a big issue in general here. And, you know, PSA testing is not recommended anymore for people who don't have symptoms. If you're starting to have problems with your urination, then you should see your primary care doctor and they will do the right thing for you. And then finally, it's been mentioned already that colon cancer is starting to happen more in young people. And I unfortunately see almost every week at least one new patient who is 45 years or younger with colon cancer, and probably half of them it's already spread. And the reason is people don't think that they're susceptible to colon cancer at a young age. That is wrong. The incidence of colon cancer age-wise is going down. We don't really understand why, but more and more young people are getting colon cancer today. So if you have any symptoms at all, you need to go to your doctor, and I'm talking about change in bowel habits, any blood in the stool, anything that, unexplained weight loss. These are things you need to see the doctor about. And even if you're young, those things can happen rarely, and you should get it checked. Don't, keep ignoring the symptoms.
Do you want to elaborate a little bit more on the possible symptoms of prostate cancer, or?
I don't deal too much with prostate
Got it,
cancer,
okay.
but, blood in your urine, trouble starting, trouble stopping, especially if you have trouble starting, then probably means that your prostate's getting enlarged. There are medicines for that. So these are all things that your primary doctor can sort out pretty.
Thank you, Dr. Hochster. Moving right along to our endocrinologist, Dr. Halberstam. Perhaps I'll spare you the introduction to diabetes, and then we'll move on to the more advanced information that you'll explain to the crowd. So I like to explain to my patients, and Dr. Halberstam will correct me where he thinks I might be wrong, but the way I think patients take better care of their diabetes when they understand the hemoglobin A1C, which is usually our primary tool that we're using to keep them, or keep you in check, all of us in check, is I describe to them we have trillions of red blood cells that are the transporters of everything we need, the oxygen, the carbon dioxide, etc. One of the closets in the red blood cell is called the hemoglobin A1C, and that only fits X amount of sugar. We all have too much sugar in our diet. For argument's sake, let's say this closet can only fit 5.5% of glucose. What happens with the rest of the sugar if your body is unable to absorb it well? You have insulin resistance, and we'll get into the whole pathophysiology of it. How does your body get damaged by the excess glucose? So the way I like to explain it simplistically is, it sticks out and it feels like shreds of glass. So instead of having this smooth cylinder red blood cell driving through your tiny arteries, be it your eyes and your kidneys and your brain and your heart and your toes, you now have a bumpy cylinder making scratches up and down the road, trillions of them, with little pieces of shreds of glass that are now starting to cut you up. And then comes clotting, thrombosis, damage starts happening to the road, to the arteries, to the small ones, and then clots start to grow. And then the whole cascade of trouble just evolves from there by your sugar not fitting into the closet and sticking out of the cylinder. You end up with trouble. And I think science tells us that the damage begins about 10 years before you see it, feel it, and maybe even before your numbers show it. But I'll turn the microphone over to our expert, Dr. Halberstam, to take it from there in explaining us a little bit more of the pathophysiology of diabetes, metabolic syndrome, and how to manage it a lot better, because I think this has significant morbidity and mortality in our community, and then we'll go through some specific questions. Thank you, Dr. Hammerstein.
Thank you. So if you look at the statistics, so right now there must probably be 30 million mentioned in the United States that have diabetes. If you look really at the statistics, most probably more than that number are undiagnosed with diabetes. So that means that most probably a quarter of the population here in America has diabetes. Inzere oilim is nachech. Okay, so that's something that everyone has to keep in mind. Part of it is because Baruch Hashem, right, we have lots of simchas, people are not that careful with the diet. I always tell people, Shabbos, obviously people aren't minding their sugar. Neshama Yisera is a wonderful thing. It doesn't burn calories. And Yidden darf to wissen that, the Rabbonim Shalom, everyone quoting the Rambam says, everything's supposed to be derech beinoni. When it comes to diabetes, derech beinoni is the way also. I don't expect that people are going to starve themselves. It was probably not a good idea to starve yourself. You have to be able, you need to have sugar. Sugar is one of the building blocks. It's what gives you energy. The cells need to have sugar, and if you don't have sugar, then you have a lot of other problems. You brought up a very interesting point, Lagaba, the hemoglobin A1C, Yedainavis vega the hemoglobin A1C. A1C is a measurement, as you said, and it measures what we call glycosylated end products. Glycosylated end products are these shards that you were talking about that can measure and that can affect the nieren, the Hals, the mugen, everything that it can have an effect on. And that's why people have neuropathy as well. Baruch Hashem, things have gotten much better. We have newer medications that we never had before. And for the first time, I actually have, or we have tools, some of these medications that maybe we'll touch upon, that actually can make a difference for a lot of these other things as well. But if you hide your head in the sand and you don't try to know what's going on with the sugar, you have a problem. It's very, very interesting you brought up about hemoglobin A1C. A1C is not as popular a measurement as we used to have before, because the problem is, as A1C is a measurement, it measures what's happened to the sugar the previous 3 months, but it's not a very, very accurate measure, because as a tzike zeya hoich and zeya nidrik, so the average can look like a normal number. So according to different organizations, 7% is a number, 6.5 is a number, but you can be 6.5, and you can have a tzike of a zeya b'drahindet, and Kenzan 50, and if you average it out, your sugar is going to come out to be okay. So Mahotab is this highest time and range now. The time and range is basically looking at numbers, fagnes, nuchnes, and we see what's going on with the numbers. The way to be able to really measure time and range, and we have a new tool, which I see a lot of my patients here also, that you can measure, we have something called a continuous glucose meter. The continuous glucose meter is basically something that you can put on. This is something I'd like to talk with Rabbi Hausch about later on also, because it's something that you wear, okay? You change it jede 2 Wochen. It gives you readings, okay? And it can give you readings mamish jede 5 minute. Now, I'm not telling everybody that they should be checking their sugars every 5 minutes, but the truth is it's an early warning sign. It has alarms that go off. It can tell you exactly what's going on. And it can make a very, very big nafkamina in terms of figuring out to do which medications are working better and everything else that makes a big nafkamina also. And this is something that, a lot of the insurances are covering now and can make a very, very big difference in terms of figuring out which medications are going to work better for the patient population as well. Everyone was talking, I think we had the question about what to do about younger patients. It bothers me a lot. Some people live on the 5th floor, the 6th floor. Everyone's going to shield Ramulatug, right? So I cannot tell you, I always ask my patients, when you go to shul, when you go to daven, you take the elevator? And they say yes. So I think about it. If you're living on a 4th floor or 5th floor, going to shul 3 times, 5 flights of stairs, up and down, that can give you 15, 20 minutes of exercise without costing you anything and can make such a nafkamina going forward also. It's those little things that really can make such a big nafkamina going forward. For me, the other thing also, everyone's talking about cholesterol, hypertension. The problem is, mahot diabetes, hypertension takes a much bigger issue. Cholesterol, we have to be much more aggressive. And therefore, it's very, very important that if you can prevent it early on, you can avoid, as we said before, all these complications that are going to happen later on.
Are there any, if you don't want to wear a continuous monitor, are there any other labs, like an insulin level certain times a day, C-peptide, fructose? Are there any other labs that you feel may give you or combine a better picture if you have a patient that has insulin resistance, but their A1C is not giving you the information you need, or you really stuck going with a monitor?
Right. So first of all, we have, the old-fashioned glucometers, right, which you have to stick the finger. So there are issues, again, I'm not going to, there's a whole much longer conversation, the issues in terms of monitoring emotional on Shabbos and things like that. So that's a little bit of a different conversation. But you can stick your finger and you can get numbers, and you can get very, very accurate numbers also from these machines. Most probably within the next year or two, we're going to have even less invasive ways of monitoring things. Google Emotional is working on a lens that you can wear that's going to be able to give you numbers. Watches exactly, that are going to give you most probably accurate numbers. So it's going to take out some of the guesswork that's related to it. And these numbers are important because the truth is, it makes you accountable. If you have a machine and you know what the number is, and you see that farnes and your sugar is running 200, maybe you'll be a little bit more careful when you have that extra piece of Kehillah that's sitting in front of you. Maybe you won't run to take it. So that becomes a very, very important consideration going forward. Like I said, no one expects that you're not going to partake if you have an opportunity by a simcha or something, and Baruch Hashem Sedu Asach Simchas. Everyone expects that you want to, and it's appropriate. No one is asking you to starve yourself, but at the same time, you have to use a bissel seichel going forward. And that really, if you prevent it, the problem is, once you have a problem with the knieen, once you have a problem with your eyes, there's no going back. But if you do something, and if you start early in prevention, then you can prevent yourself from having something as we go forward.
Do you think, in hindsight, that maybe, we're always demanding of the patients to exercise more and to diet better, to drink more water. But I think as difficult as you see it is in the frum community, in the Heimische community with simchas all the time and things, do you think we could perhaps bend the protocols a little and use things like metformin earlier on than textbook? Like, if you know a patient that's a little overweight, has a strong family history, maybe his A1C is slightly bumped, would it be outrageous to say, I know your family history, I know you're struggling with your weight, you're a little overweight, or you're moderately overweight, it's going to take you time. Let's give you something to help give you the push and prevent you from getting it. I'm picking something like metformin and not Ozempic yet, because I'm looking at something that has like a long safety track record.
So it's funny you should ask about metformin. Metformin, or glucophage, was a medication that actually got approved when I was doing my fellowship, And it's funny because this is not gay what's going on with Ozempic, and you'll hear why in a second. When I started, so gewesen zwei medications, as I had type 2 diabetes. There was something called sulfonylureas, which basically, as I had diabetes from ibit saying most probably sulfonylureas don't work anymore. And then we had insulin. So what used to happen is we tried the sulfonylureas. Once you had diabetes, for saying it didn't make a difference anymore. And then in 1995, it had been approved already in Europe. I think in Mexico and Eretz Yisrael it was approved, maybe even 10 years before that. But in 1995, here in America was when metformin got approved. And I still remember my director in my fellowship program used to tell his patients when he used to come in, if you know somebody in Eretz Yisrael, you know somebody in Mexico, bring it. Have them get it to you, and almost like bootlegged. It was like a, it was like a black market in order to get the medication. So Baruch Hashem, over the last, it was almost 30 years now, we have a lot of newer medications, and the truth is that the newer medications have unbelievable koiches that we didn't have with some of the other medications. But metformin still has a role and certainly works well in conjunction with a lot of these other medications. It's high synergy. So metformin works, as you said, for insulin resistance. It helps for the liver, And in women, very often we have something called PCOS. It makes a very, very big nafkamina. And certainly metformin should, at least initially, most probably is an appropriate medication to start as first line. Doesn't mean that we shouldn't use the other medications. That's the beauty of metformin, is that it plays very well with the other medications as well.
I was particularly bringing it up because perhaps this is something with a strong enough safety profile that we could really bring on early in the pre-diabetes stage, not once they already have an A1C of 6, but if they have an A1C of already 5.7, and they're overweight, they have a family history, you want to use something that we know has a long safety profile. That's why I mentioned it. But let's move along to the newer medications. When would you feel it's appropriate? Do you feel the oilam is exaggerating its use? Do you feel there's enough safety data on it? And most of all, do you think it's okay that people are literally shopping for it from magazines, Heimish magazines? I opened up one Shabbos, my kid brought to the house one of the Heimish magazines, and they have a full-page ad, call us for your Ozempic for weight loss. I'm like, this doesn't sound right. Do they know the patient's history? Do they know his medications? Do they know the family history? Do they know his labs? Get doctors free consult. What are your comments about the oilam going to grab it and buy it and use it without the comprehensive primary care specialty plan involved in their care?
So I don't want to keep everyone here all night. The truth is that if we start talking about Ozempic, there are a lot of different parts that we have to talk about. The one thing I just want to put up is Dr. Rahmani, and we were talking about in terms of screening. This is actually, this actually came out, and this is very, very important because I agree that I think that screening is very, very important. Ozempic, they came out last week that if you're on Ozempic, then basically if you're going for a colonoscopy, you should not take it a full week before, okay? Because one of the things that it does is something that's called gastric emptying. It delays gastric emptying. People who are going lemushal for elective surgery, okay, if they're on Ozempic, should not take it for at least 1 week before that they're taking it, because unfortunately we've seen there have been some complications. So that's just, a piece of information that I think is very, very important. Ozempic has made my life very, very difficult, okay?
Sure.
Okay, it's affected my kavuna during davening because I mamish have people coming over. I mamish people line up as I'm walking out of shul to say, do I think that they're a candidate? I think that there is a lot to be said for it, okay? For not just Ozempic, there's Wegovy, there's Trulicity, there's Mounjaro. There are a lot of drugs now that are called was heist the GLP-1 class. And certainly for a lot of patients, certainly it helps with people who are heavy, and it can make a very, very big nafkamin. And we're actually finding that it may make a nafkamin. Even there was a study that just came out that it may actually be cardioprotective as well. So there may be some benefits there also. Before I get into a little bit more about how I feel about it and where it fits in, I also just want to mention that there's another class of agent that's called the SGLT2 class. I think a lot of patients are on it. There's a medication called Jardiance for Xiga. The advantage to that medication also is that, koydem kol, it's a pill. It actually may help with weight loss also, but we have a lot of studies that showing that it can zan git for the nieren. It's definitely good for the heart as well, that it may be protective, and works very well with metformin. Actually comes in combination with metformin, and the studies have shown that it really is making a very, very big difference going forward. It really was the first drug that ever showed to do zweierlei type of complications that you can have with diabetes, and this is related to what you're talking about the glycosylated end products. The sebus was heist microvascular complications and macrovascular complications. Microvascular complications are related to retinopathy, to the nieren, to neuropathy. Macrovascular complications are stroke, a heart attack, and these newer medications for the first time showed that there can be a nafkamina when it comes to these macrovascular complications as well. So a lot of patients can do very, very well if they consider taking one of these SGLT2s. The problem with Ozempic, okay, and I don't mean it's a problem, I think that it's appropriate, is that people think that that basically they have no responsibility anymore.
No effort or energy needs to be put in.
Okay, and
take it and run.
Right. Basically, you take it, and therefore I have no ischayvus anymore. Everyone has to have an achrayus to take care of themselves. To just stam go on a shot is not going to solve the problem. The other thing is also is that what Ozempic does, if someone eats just stam for the sake of eating, then Ozempic isn't going to make a nafkamina. If you take Ozempic, it does have an appetite suppression, but a lot of times people just eat for the sake of eating, And it really is not going to affect them either. And people come in, they have this expectation. I had once, I'll tell you, I had a woman came to me one time and she said, "Ich mach Chasen in 4 Wochen, misverlieren 30 Pfund, I can't fit into my gown." So I look at her. So she says, "I want to go on the shot." And I looked at her and I said, "That's not the way the medication works. If you want to exercise, you want to diet, then mistam, the medication is going to help as well." The other thing is I think that the Olam has this misconception that we're not giving it to them either. The medication doesn't work. The problem is that the insurances have given us a lot of trouble. Most of the insurance have an automatic exclusion that you just can't get the medication. I know at ODA we have a whole prior authorization. They work very, very hard to try to get it for someone who's appropriate, but very, very often we just can't get it because the insurance is not going to cover it. So it's just an important point that everyone has to consider. It is a very, very good drug. Unfortunately, we don't have that much data. It hasn't been around that long.
That's what bothers me about it.
But again, it's something that if you monitor, it is a physiologic drug, meaning that it is basically working on a hormone that we do know a lot about. And the truth is that medications, as Oivia Zempic, have been out for a while. We had something with Saskahais Bayeta, by Durian, that's been around for more than 10 years. And the truth is that Baruch Hashem, we have not seen, again, I don't want to say Chas Hashem that we're going to, I hope that in 20 years from now we're not going to see this as a problem, but the truth is that I've seen tremendous success, but it has to be done zusammen with all these other things that we're talking about, the diet, the exercise, and other medications, and just using common sense and using seichel when we're trying to deal with what we're doing.
Thank you, Dr. Halberstam. It was a wonderful review. I have one more topic I'd like to bring up. It's a little bit of a sensitive topic, but I think it's a very important topic. It's become a more sensitive topic since COVID, but I think it's something we all need to go home and think about very honestly. I notice in the 20 years that I've been working in Williamsburg or in Muncie, flu season's around the corner. And a couple of months, sometimes it starts early. Every year, the Heimish offices are incapacitated by sick people, high risk, pregnant, elderly, young, hospitalized, no beds. It becomes a churban. You cannot get a sick patient in with anything else into a New York City hospital. Lie there because of a bad reputation with vaccine manufacturers, which I'm not going to get into. People shy away from it and they're scared. But I think that people need to take an honest look. It's been around for many years with a high safety record, a very high safety record. I'm hard pressed to think of any cases of somebody I know really hurt from a flu shot. I challenge anybody in this room to find me one. And I think some years it works 100%, and some years it works a little less, and it's not such a good match. It's matched to the season, but I think it's extremely important. And I get excuses from patients that get it a day before they got the flu, in peak flu season. I got it last year, but it didn't work. Rabboisai, it takes time to work. I have a child staying in my house, a nephew, with a brain tumor on chemo and radiation. I don't want to tell you the fear in his eyes when somebody coughs. We have around us in Shil, in the gas, in the stores, everywhere, patients, people, friends, neighbors that are immunocompromised. We have an achrayas to them. It's not for yourself, to protect them. The shot is nothing. Now, I was coming here by a taxi. I jumped into a taxi. I didn't have gas in my car. The car was broken. Let me run here fast. I said to the guy, I see you have a fancy car. He says, yeah. I said to him, if this company, whatever company it was, if they made one bad batch of one model over the last 75 years, so you wouldn't buy from this company anymore? He said, of course I would. So we have a problem where people don't like a certain vaccine that the manufacturer makes, so that's it. We're not touching any of their medicines. We're not touching any of their vaccines that they made that have saved thousands of lives. Mizan, you have to be smarter than that. How could we let this go by and let our neighbors get sick And it's not even about the flu shot. Before I moved upstate from Williamsburg to Muncie, I had a baby in the office that did not have the rota vaccine, and this baby had profuse vomiting and diarrhea and died. I've had another baby that ended up in the ICU with super high sodium. This is an optional, easy shot that I never saw one sick baby from. Pneumonia shots, meningitis shots, Hib. Today we get 5 croup calls a night in Hatsulu, where I am, in the last week. We don't know now. They're so behind in vaccines. Is it whooping cough? Is it epiglottitis? Is it croup? Whose is this? Because they're so behind in vaccines. Rabbi Sai, we have to wake up. We can't do this. We're hurting ourselves. We can't be so. We can't falozich on somebody that gives. It's a perfect example of lashon hura. Yes, there are some issues. There were some issues in the manufacturers first made it. The first polio vaccines 50, 60, 70 years ago also had problems. But we can't take all the benefit that it brings to us, just like with medications. These are the Eibush that gave us such life-saving medications for diabetes, for cholesterol, for blood pressure. They're giving people 20, 30, 40 years of life back. How could we go take vaccines that are saving lives? Weil eine von Gas sucht und that, sucht mich Chatin etwas. Ich suche allemal die Frauen. I don't belong to the bus stop committee. Ich suche nicht wie zu backen Challe und Kegel. Such mir nicht wie zu researchen vaccines. Ich gehe wasen. Du willst hören von der anderen Seite, Kim lernen auch et. Ich suche nicht, dass jeder Shot es gibt. Aber Kim mit der open mind, seht, sie das Shot-Menschen Tage? Lass mir hören der MS. Sie das helft Menschen. Wie kann man losen, als noch ein Winter soll gehen, als ein Winter soll sein, hinderte Menschen, wir sind krank, und haben nicht das Spetul reinzugehen. Ich sage, bete, ich gehe heim, schmiesse sie über, trachte sie über, Ernstheit, sie das ist der richtige Weg, also wie man geht. Und man soll tun, wenn der Eibische so ein Bench soll sein, ein Gitt gebenchte Jür. Schkoyach.